My name's Vic Riley. I'm a consultant radiographer. I've been reporting radiographs for over 20 years, and so familiarity with interpreting osteoarthritis is something that I do daily. So a little bit about the hip joint. So the hip joint, the primary function of the hip joint is to provide dynamic support for the body's weight while facilitating force and transmitting load from the axial skeleton into the lower extremities. So if you think about the amount of weight that is going through that femoral neck, I think if we were a car, we would have been recalled many years ago for an upgrade. So that femoral neck and that femoral head takes an awful lot of weight. So some bony landmarks that we should be familiar with. So the pink line is the iliopectineal line. We've got the ilioischial line, the acetabular fossa, the anterior and posterior wall of the acetabulum, and our teardrop. Now, the radiographs that are really important would be your AP pelvic X-ray, a separate AP view of the hip if required, if it wasn't all included on the pelvis. You may have a turned lateral radiograph or a horizontal beam radiograph where we don't move the patient, but we move the equipment to enable us to be able to see that second view. So the aim in radiography is to try and get two views, at least at 90 degrees to one another if possible. That's far easier in the wrist, for example, than it is within the hip. So on here, we want to be able to see the acetabulum, our femoral head. We can see our greater trochanter and our lesser trochanter. So we will be able to assess joint space reduction, anatomical alignment on all of our radiographs. Soft tissue signs that you may be able to see. So on X-rays, the darker area is going to be fat. So if we can see fat planes, that's important to us, particularly if we're assessing for inflammation or soft tissue swelling, particularly in the context of trauma, joint effusion, inflammation, because these fat lines may be displaced, may be obliterated, or may be blurred. So we're going to look at the X-ray today. So what are going to be our findings on our X-ray? So the bony features of osteoarthritis, such as joint space loss. So what are our findings going to look like? So we want joint space reduction. So I've got a normal radiograph on our right-hand side. On my left-hand side, I've got joint space reduction. Now it's asymmetrical joint space reduction. And we particularly see that in the knee, don't we? Because the medial joint compartment can be significantly affected, whereas our lateral joint compartment can be well preserved. So it's asymmetrical joint space reduction. You're most often going to see it in the weight-bearing portion of the joint. So that's the superior. So this is the portion that we're going to measure. So you've got this radiograph and the patient's complaining of symptoms there. You would suggest the patient has osteoarthritis. So we have subarticular sclerosis. So remember, when the cartilage gets worn away, bone rubbing on bone is going to create more bone. Now, this is a useful feature for particularly, when fractures, we want them to heal, then we have to maintain alignment so that the bones are touching because we want new bone formation. But again, if we've got cartilage worn away, with that femoral head is going to be rubbing on that acetabulum, creating a bony reaction. We've got asymmetrical joint space reduction. So the superior lateral aspect of this joint is narrowed in comparison with the medial aspect. We've got subchondral cystic changes. So these are lucencies within the articular surface of our joint. Remember where that synovial fluid is being pushed into defects due to the cartilage not protecting the joint surface anymore. And we've got femoral neck buttressing. So this is smooth new bone formation. So this is a reaction to the load distribution coming through that joint. So again, they're creating more, the body is creating more bone to stabilize that weight. And we've got marginal osteophytes. So again, bone rubbing on bone is going to create more bone. So if we look at this patient, significant, almost bone on bone, I would say, joint space reduction, superior medially. We've got extensive subchondral cystic changes, both within the femoral head and within the acetabulum. We've got large marginal osteophytes laterally, which in themselves are likely to be causing the patient a degree of impingement and restricted rotation, and we've got that smooth new bone formation medially in keeping with femoral neck buttressing. So we've said joint space reduction is really paramount in finding osteoarthritis. Remember, our plain radiographs are insensitive to the early features. So if you can see joint space reduction, a consideration should be osteoarthritis, particularly in the absence of any inflammatory findings. However, as you can see in this patient, 59-year-old patient, 6 months history of right hip pain, painful and internal rotation and flexion. The suspicion was this patient has osteoarthritis. Now I've got an example of our patient before in our bottom right-hand corner. So is our patient have the indications on radiographs of osteoarthritis? Well, it's not asymmetrical joint space narrowing. This is pretty symmetrical, so the whole of the joint is narrowed. There is very little to no subarticular sclerosis. There are no osteophytes. Now we have lucency, so we could have subchondral cysts or we could have erosions, but remember, erosions within the hip joint are not common in osteoarthritis, and there is no femoral neck buttressing. So this patient has an underlying inflammatory process. So the differential for this is an inflammatory arthropathy, such as rheumatoid arthritis. However, in fact, this patient had a septic joint. So remember, the take-home point, just because there's joint space reduction doesn't necessarily mean it's degenerative in nature. So who might have or develop osteoarthritis based on their anatomy? So the patient may have dysplastic femur. They may have a dysplastic acetabulum. So I'll show you some radiographs now that will allow you to assess whether the patient has an underlying skeletal abnormality, which will predispose them to developing osteoarthritis. So if you're unfamiliar with reviewing x-rays, then this is something that you will be able to measure. However, with pattern recognition, if you're viewing x-rays frequently, this is something that you will be able to eyeball. So the normal angle between the patient's femoral shaft and femoral neck is about 135 degrees. Now that angle can vary, and patients therefore have coxa-vara if the angle is less than 120 degrees, or they could have coxa-valga if the angle is over 135 degrees. Now, we can see in this patient here, so if I put the line up through both of my femoral shafts, and then I draw a second line through my femoral necks, I can see that the patient has this walkie stick or hook deformity. So this is going to change the load distribution, and you can see the patient's likely to have a degree of impingement laterally, particularly on the left, because they haven't got that smooth contour. So if you're looking at your patient's radiograph and you can see that they have a coxa-vara deformity, you should be aware that this can lead to gena valgum deformity at the knee. The patient may have a limp, Trendelenburg if unilateral, or they could have a waddling gait if they have a bilateral deformity. If it's unilateral, the patient is likely to have a leg length discrepancy. The patient will have a prominent greater trochanter and weak abductors. So that's coxa-vara deformity. Coxa-valga, when our femur is sitting nice and proud. So again, this is going to change that load distribution into that femoral head and neck. So if I draw my lines, I can see that again, that angle is going to be over 135 degrees. This is more like 150. Now look at our right femoral head. How do I know that that's not osteoarthritis? Because I've got articular sclerosis, I've got lucency within my femoral head, but actually the joint space is normal. There are no findings within the acetabulum. And if you think back to our radiograph that we looked at with osteoarthritis, those findings are on both sides of the joint. So we have subarticular sclerosis on both sides of the joint. We have subchondral cystic changes on both sides of the joint with joint space reduction. So this is collapse of the femoral head secondary to avascular necrosis due to the load distribution changes affecting the blood supply to that femoral head. So again, this is something that you will be able to eyeball going forward. Have a look at your proximal femur. Does that angle look normally? So coxa-valga can lead to the patient having an acetabular dysplasia. It will increase the stress and early degenerative changes within the medial aspect of the knee and can lead to genivarum deformities at the knee. The patient may have decreased extension, external rotation and adduction. So that's a deformity of the proximal femur. The patient may also, or instead, have a dysplasia of their acetabulum. So the patient should have a normal acetabulum, which is anteverted. So if it's anteverted, it allows for the hip flexion greater than extension. Now, our first radiograph, we were identifying the anterior and the posterior wall of our acetabulum. So we can see the yellow on our normal is the posterior wall, the red is our anterior wall. A retroverted acetabulum occurs when the acetabulum is angled less than 15 degrees anteriorly. So the acetabulum may have relative retroversion, so it's still anteverted but less than 15 degrees, or it could be truly retroverted. Patients who have retroverted acetabulum usually have a prominent ischial spine, and they have this figure of 8 appearance, which I'll discuss when we talk about impingement. So this patient here, so this is anterior and posterior wall, and you can see that the anterior wall is going to stop that patient having those ability to flex. So the patient will present with hip pain, possibly clicking or catching or popping. They're likely to have femoroacetabular impingement symptoms. They may find that their hip gives way or that they have stiffness. Our take-home points for today's talk: does the patient have clinical signs of impingement? When you're reviewing the AP radiograph, what can you diagnose from it? So is the femoral head and shaft and angle normal? Is the acetabula normal? Is it retroverted? Does it have over or under coverage of the femoral head? Do you have any bony features of cam or pincer impingement? Is there a bony protuberance at the junction of the lateral aspect of the patient's head and neck? Do we have an over coverage of the femoral head with the acetabulum? Are there any secondary degenerative features of osteoarthritis, which is joint space reduction, subarticular sclerosis, subchondral cysts, and marginal osteophytes? In the context with no inflammatory findings. If you have any joint space reduction and you have inflammation, then you must always consider the alternative of a septic joint, infection, or an inflammatory arthropathy. Thank you.
The question from me is, Vicky, if there is an inflammatory arthritis, of course, it doesn't affect the hip joint as much as the other, like the knee, ankle, and the hands and the elbows. If there are inflammatory features, what are the things we are looking at in the hip joint?
Okay, so universal, like kind of uniform joint space reduction. Whether the patient's got any articular irregularities. I'm quite happy to, would you like me to share a couple of films of inflammatory arthropathy?
Why not? Please do.
Okay.
Please do that. When working in the rheumatology, that I would always like to see how it looks like on the plain films.
Right, I'll just share my screen with you again then.
I think somebody have asked the same question as well on the chat box. What are the features of inflammatory arthritis on the X-ray?
Okay, so we can see here, so this is the septic joint that I showed you. Let me just I'll hide this for you. So you've got increased osteopenia. So any inflammatory findings, whether that might be in our hands or knees, if you've got an increased blood supply, then the likelihood is that you've got hyperemia. So the joint and the bone have the same blood supply, so you're going to get, it's going to appear more loosened. So rapid joint space reduction. So osteoarthritis is a joint space reduction that takes time. So if you've got rapid loss of joint space over a short period of time, then you must think that maybe there's an underlying inflammatory process that's destroying the cartilage. So non-uniform joint space reduction. This patient here has got a little bit of sclerosis, but they've got articular lucencies. Now you may look at them and think, oh, could they be cysts? But actually this is a well-defined defect. So you can see that this is actually an
It
erosion,
is
and we've
on
got
the right
that,
side, yeah.
yeah, absolutely, that demineralization. So this is
Yeah.
rheumatoid arthritis. So rheumatoid arthritis is going to infect the entire joint. So you have that inflamed synovium that creates that pannus that then destroys the cartilage. So it starts from the outside and then comes all the way into the joint. So unlike osteoarthritis, which can be asymmetrical, rheumatoid is an inflammatory process. It's going to affect the whole joint. So again, if it's in your knee, it's going to affect all compartments of the knee. It's not just going to be affecting the medial joint compartment. It will affect the whole lot. And this patient did go on to have secondary osteoarthritis. So we've got joint space reduction due to the inflammation, but now they've got subarticular sclerosis and subchondral cystic changes due to that lack of cartilage that's been destroyed due to the inflammatory process.
Okay. That's it for tonight. I think it's a tonight in Pakistan, so this is still evening here, but it's tonight in Pakistan. Well, Vicky, thank you very much for wonderful presentation, and thank you very much for taking the time to explain us that helps the physio to look at the X-ray and manage the condition well. All right, I believe that would have helped them to understand the X-ray and then understand the grading of it, and then understand the management plan with regards to where they stand with their exercise plan and all of this. So thank you very much once again, and yeah, we will give you we will ask you one more time, I think, at some point, to present maybe a knee or an ankle in the future. But that was really, really helpful, and thank you very much once again.
You are very welcome. Thank you so much for inviting me, and thank you very much to everybody listening to me. And yes, I'm very happy to come back if you invite me again.
Thank you, Vicky. Thank you. Thank you very much. All good. Thank you. Thank you, everybody.